Question 1. The assessment process reveals a situation where a hospital outpatient coder notices that a physician's documentation for a specific procedure appears to be less detailed than typically required for the assigned CPT code, yet the claim has been submitted with that code. The coder also observes that a colleague frequently assigns higher-paying codes based on minimal documentation. Which of the following actions best upholds the principles of fraud and abuse prevention within the Certified Coding Specialist Hospital Outpatient (CCSB) regulatory framework? Option A. Adjust the coding on the claim to a lower-paying code that is more clearly supported by the limited documentation without reporting the issue. Option B. Ignore the discrepancies, assuming they are minor oversights, and continue coding as usual to avoid disrupting workflow. Option C. Report the observed discrepancies and the colleague's coding patterns to the hospital's compliance officer and follow established internal reporting procedures for investigation. Option D. Discuss the documentation concerns directly with the physician to request clarification and potential amendment of the record. Correct answer is C. Report the observed discrepancies and the colleague's coding patterns to the hospital's compliance officer and follow established internal reporting procedures for investigation. Explanation. The assessment process reveals a scenario where a coding specialist is presented with conflicting information regarding patient care documentation and billing practices. This is professionally challenging because it requires the coder to navigate potential discrepancies that could indicate fraudulent activity or abuse, while also ensuring accurate and compliant billing for legitimate services. The coder must exercise careful judgment to distinguish between genuine documentation errors and intentional misrepresentations. The correct approach represents best professional practice because it prioritizes adherence to the False Claims Act and the Anti-Kickback Statute, which are foundational to preventing fraud and abuse in healthcare. By meticulously reviewing documentation against coding guidelines and reporting identified discrepancies through established compliance channels, the coder upholds their ethical and legal obligations. This proactive stance protects the organization from financial penalties and reputational damage, and more importantly, safeguards the integrity of the healthcare system. An incorrect approach that involves overlooking or ignoring discrepancies, even if seemingly minor, fails to meet the standard of due diligence required by federal regulations. This inaction could be interpreted as tacit approval of potentially fraudulent practices, violating the spirit and letter of laws designed to prevent healthcare fraud. Another incorrect approach, such as directly confronting the physician or department without following established compliance protocols, bypasses necessary oversight and could lead to premature conclusions or mishandling of sensitive information, potentially creating legal liabilities for the coder and the organization. Furthermore, an approach that involves altering documentation to align with billing expectations is a direct violation of coding ethics and constitutes falsification of records, a serious offense. Professionals should employ a decision-making framework that begins with a thorough understanding of relevant regulations, including the False Claims Act, Stark Law, and Anti-Kickback Statute. When discrepancies arise, the process should involve 1. Objective review of all available documentation. 2. Comparison against established coding and billing guidelines. 3. Consultation with supervisors or the compliance department if uncertainty persists. And 4. Adherence to the organization's internal policies for reporting and resolving compliance issues. This systematic approach ensures that all concerns are addressed appropriately and ethically. Question 2. Which approach would be most appropriate for a Certified Coding Specialist Hospital Outpatient (CCSB) when encountering a patient record with multiple documented diagnoses, where the physician's notes do not explicitly state which condition was chiefly responsible for the outpatient services provided? Option A. Assign the diagnosis that is most frequently mentioned throughout the medical record as the principal diagnosis. Option B. Code only the diagnosis that seems most severe based on the coder's clinical interpretation. Option C. Query the physician for clarification on the principal diagnosis and the relationship between documented conditions. Option D. Assign the diagnosis that appears first in the physician's narrative as the principal diagnosis. Correct answer is C. Query the physician for clarification on the principal diagnosis and the relationship between documented conditions. Explanation. This scenario presents a common challenge in medical coding, accurately assigning ICD-10-CM codes when documentation is ambiguous or incomplete, particularly concerning the sequencing of diagnoses. The professional challenge lies in adhering to official coding guidelines while ensuring the claim accurately reflects the patient's encounter and supports medical necessity for services rendered. Misinterpretation or misapplication of coding rules can lead to claim denials, audits, and potential compliance issues. The correct approach involves a thorough review of the medical record to identify all documented diagnoses and procedures. It requires applying the ICD-10-CM official guidelines for coding and reporting, specifically focusing on the sequencing rules for principal and secondary diagnoses. When documentation is unclear regarding the relationship between conditions, the coder must query the physician for clarification. This ensures the principal diagnosis accurately reflects the condition chiefly responsible for the outpatient services provided, as per Guideline I.B. 4a. Querying the physician is best professional practice because it upholds the integrity of the coding process, ensures accurate data for quality reporting and reimbursement, and aligns with the ethical obligation to code truthfully and completely based on documented facts. An incorrect approach would be to assume the relationship between diagnoses without explicit documentation, or to code based on personal interpretation of the patient's condition. For instance, coding a secondary condition as the principal diagnosis simply because it appears first in the physician's notes, or because it seems more severe, violates the established sequencing rules and the principle of coding based on documented evidence. This failure to follow official guidelines, e.g., Guideline IB 4. Regarding the principal diagnosis, constitutes a regulatory failure. Another incorrect approach would be to code only the most significant condition without considering other diagnoses that may have influenced the patient's care or the services provided, potentially leading to an incomplete or inaccurate representation of the encounter. This also represents a failure to adhere to comprehensive coding principles and guidelines. The professional decision-making process for similar situations should begin with a complete review of the medical record. If ambiguity exists regarding diagnosis sequencing or the relationship between conditions, the coder must consult the ICD-10-CM official guidelines for coding and reporting. If the guidelines do not provide sufficient clarity, the next step is to initiate a physician query. This systematic approach ensures that coding decisions are evidence-based, compliant with regulatory requirements, and ethically sound. Question 3. The review process indicates that a patient's medical record includes documentation from the physician detailing the patient's frequent hospitalizations due to uncontrolled diabetes, exacerbated by the patient's inability to afford healthy food options and lack of stable housing. The physician notes that these social factors are significant barriers to the patient's adherence to their treatment plan. Which approach best reflects the appropriate coding of these social determinants of health (SDO) factors for risk assessment purposes within the Certified Coding Specialist Hospital Outpatient (CCSB) framework. Option A. Infer the patient's need for social support services based on the documented barriers and assign appropriate SDO codes to reflect this inferred need. Option B. Code all documented SDO factors that are identified by the physician as impacting the patient's health status and treatment adherence, provided they are supported by the medical record. Option C. Focus solely on the clinical diagnoses and procedures documented, as SDO factors are considered supplementary information and not relevant for risk assessment in outpatient coding. Option D. Assign codes for the patient's uncontrolled diabetes and frequent hospitalizations, but do not code the SDO factors as they are not primary medical diagnoses. Correct answer is B. Code all documented SDO factors that are identified by the physician as impacting the patient's health status and treatment adherence, provided they are supported by the medical record. Explanation. This scenario presents a professional challenge because it requires coders to move beyond purely clinical diagnoses and incorporate socioeconomic factors that significantly impact patient health outcomes and resource utilization. The risk assessment approach is crucial here as it directly aligns with the evolving focus on social determinants of health (SDO) within the U.S. healthcare system, particularly as it pertains to reimbursement and quality metrics. The correct approach involves accurately identifying and coding documented SDO factors that are clinically relevant and impact the patient's care plan or risk profile. This is best professional practice because it allows healthcare providers to capture a more complete picture of the patient's health status, which can inform care management, identify needs for social support services, and contribute to more accurate risk adjustment for quality reporting and reimbursement. Centers for Medicare and Medicaid Services, CMS, and other payers are increasingly emphasizing the importance of ESDO data for understanding population health and disparities. Coding these factors accurately ensures that the patient's overall health burden is recognized, which can lead to more appropriate resource allocation and a better understanding of health inequities. An incorrect approach would be to ignore documented ESDO factors, assuming they are not relevant to coding. This fails to capture critical information that influences patient care and outcomes, potentially leading to underestimation of patient complexity and needs. Ethically, it can perpetuate health disparities by not acknowledging the systemic barriers patients face. Another incorrect approach would be to infer or document ESDO factors that are not explicitly stated in the medical record. This violates the principle of accurate and truthful coding, as coders must rely on documented evidence. It can lead to fraudulent claims and misrepresentation of patient conditions. Furthermore, it undermines the integrity of the data used for research, quality improvement, and public health initiatives. The professional decision-making process for similar situations should involve a thorough review of the entire medical record, looking for explicit documentation of ESDO factors by the physician or other qualified healthcare professionals. Coders must understand the specific ICD-10-CM codes available for ESDO and their appropriate application. When in doubt, coders should query the physician for clarification to ensure accurate and compliant coding. This process emphasizes collaboration, adherence to coding guidelines, and a commitment to capturing comprehensive patient data. Question 4. The analysis reveals an operative report detailing a laparoscopic cholecystectomy performed on a patient. During the procedure, an intraoperative cholangiogram was also performed to assess the common bile duct. The surgeon's documentation indicates the cholangiogram was performed to evaluate for potential stones, but no stones were identified, and no further intervention on the bile duct was required. Considering the principles of accurate surgical procedure coding and Medicare's coding guidelines, what is the most appropriate coding approach for this scenario? Option A. Report the laparoscopic cholecystectomy code and the intraoperative cholangiogram code without any modifiers. Option B. Report only the laparoscopic cholecystectomy code, as the intraoperative cholangiogram was an integral part of the evaluation during the primary procedure. Option C. Report the intraoperative cholangiogram code separately and do not report the laparoscopic cholecystectomy. Option D. Report the laparoscopic cholecystectomy code and the intraoperative cholangiogram code, appending modifier 59 to the cholangiogram code. The correct answer is D. Report the laparoscopic cholecystectomy code and the intraoperative cholangiogram code, appending modifier 59 to the cholangiogram code. Explanation. This scenario presents a common challenge in surgical coding, accurately reflecting the complexity and extent of a procedure when multiple related services are performed. The challenge lies in determining whether to code each distinct service separately or to utilize a more comprehensive code that encompasses the entire operative session. Adhering to Medicare's National Correct Coding Initiative, NCCI, edits, and the principles of accurate representation of services rendered. The correct approach involves identifying the primary surgical procedure and then evaluating if any secondary procedures are separately billable or if they are integral components of the primary procedure. This requires a thorough understanding of CPT guidelines, NCCI edits, and payer-specific policies. In this case, the laparoscopic cholecystectomy is the primary procedure. The intraoperative cholangiogram, while a distinct diagnostic step, is often considered an integral part of a complex cholecystectomy, especially when performed to assess for common bile duct stones. Coding it separately without proper justification or modifier would violate NCCI principles and potentially lead to overpayment. Therefore, reporting only the laparoscopic cholecystectomy, with appropriate documentation supporting the cholangiogram's necessity as part of the primary procedure, represents best professional practice. This aligns with the principle of reporting the most comprehensive code that accurately describes the service, avoiding unbundling of services that are considered part of a larger procedure. An incorrect approach would be to code both the laparoscopic cholecystectomy and the intraoperative cholangiogram as separate procedures without considering their relationship. This violates NCCI edits, which are designed to prevent improper payment for services that are considered bundled or integral to another procedure. Specifically, reporting the cholangiogram separately when it is performed solely to evaluate the common bile duct during a cholecystectomy, without additional findings or interventions on the duct, would be considered an unbundling error. This is a regulatory failure as it misrepresents the services provided and can lead to fraudulent billing. Another incorrect approach would be to code only the intraoperative cholangiogram and omit the cholecystectomy. This is a significant misrepresentation of the patient's care and a clear ethical and regulatory failure. It fails to capture the primary surgical intervention and would result in underpayment for the services rendered. But more importantly, it inaccurately documents the patient's medical record and the provider's actions. A third incorrect approach would be to append a modifier to the cholangiogram to indicate it was a separate procedure, such as modifier 59, without sufficient documentation to support its distinct and separate nature from the cholecystectomy. Modifier 59 is intended for situations where a procedure is performed at a different site or session, or is otherwise distinct from another procedure. In this context, an intraoperative cholangiogram is typically performed within the same operative field and session as the cholecystectomy, making modifier 59 inappropriate without exceptional circumstances clearly documented. This would be a coding error leading to potential claim denial or recoupment due to improper use of modifiers, violating payer guidelines, and potentially leading to accusations of billing fraud. The professional decision-making process for similar situations involves a systematic review of the operative report, identifying all documented procedures and services. This is followed by consulting CPT guidelines for the primary procedure, understanding any included services or components. Next, NCCI edits must be reviewed to determine if any reported procedures are bundled. If multiple procedures are performed, the coder must assess if they are distinct and separately billable, considering the use of appropriate modifiers only when justified by documentation and payer policy. Adherence to these steps ensures accurate coding, compliance with regulations, and ethical representation of patient care. Question 5. Risk assessment procedures indicate a patient presence with symptoms suggestive of a blockage in a major venous return pathway from the lower extremities and abdominal organs to the heart. The physician's documentation specifically identifies a thrombus within the inferior vena cava, noting associated edema in the lower extremities. Which coding approach best reflects the documented anatomical and physiological findings? Option A. Code for the symptom of pain in the lower extremities. Option B. Code for generalized edema without specifying the underlying cause. Option C. Code for the anatomical location of the thrombus and the documented physiological manifestation. Option D. Code for a general venous thrombosis without specifying the anatomical location. The correct answer is C. Code for the anatomical location of the thrombus and the documented physiological manifestation. Explanation. Scenario analysis. This scenario presents a challenge in accurately coding a patient encounter involving a complex anatomical structure and a related physiological process. The coder must demonstrate a foundational understanding of both anatomy and physiology to correctly identify the primary condition and any associated complications or manifestations, ensuring appropriate reimbursement and accurate patient record maintenance. Misinterpreting the anatomical location or the physiological consequence can lead to significant coding errors. Correct approach analysis. The correct approach involves a systematic review of the medical documentation, focusing on identifying the specific anatomical site of the abnormality and the physiological impact described. This requires a strong grasp of anatomical terminology and the ability to link symptoms and findings to specific body systems and structures. For example, understanding that the inferior vena cava is a major vein carrying deoxygenated blood from the lower and middle body into the right atrium of the heart is crucial. If the documentation describes a thrombus within this vessel, the coder must recognize this as a venous thrombosis affecting a specific anatomical location. This aligns with best professional practice by ensuring the code accurately reflects the patient's condition as documented, adhering to the principles of specificity and completeness mandated by coding guidelines and payer requirements within the U.S. regulatory framework for CCSB. Incorrect approaches analysis. One incorrect approach would be to code based solely on a general symptom, without correlating it to the specific anatomical structure and physiological process described. For instance, coding for pain, without identifying the source of the pain within a specific anatomical region, or understanding the underlying physiological cause, would be a failure to adhere to coding specificity requirements. This violates the principle of accurate representation of the patient's condition. Another incorrect approach would be to select a code for a condition that is anatomically related but not precisely documented. For example, if the documentation clearly states a thrombus in the inferior vena cava, coding for a general deep vein thrombosis without specifying the location would be incorrect. This demonstrates a lack of understanding of anatomical precision and can lead to inaccurate data collection and reporting, potentially violating payer policies that require precise anatomical coding. A further incorrect approach would be to ignore physiological manifestations described in the documentation. If the anatomical issue has led to a specific physiological consequence, such as impaired blood flow or edema, and this is documented, failing to capture this physiological impact in the coding would result in an incomplete representation of the patient's clinical picture. This overlooks the comprehensive nature of medical coding and the importance of reflecting the full clinical picture for accurate risk adjustment and quality reporting. Professional reasoning. Professionals should approach this by first identifying the chief complaint and then meticulously reviewing the physician's documentation, paying close attention to anatomical terms and descriptions of physiological processes. They should cross-reference these findings with their knowledge of anatomy and physiology, utilizing coding manuals and official coding guidelines to select the most specific and accurate codes. When in doubt, consulting with a clinical expert or seeking clarification from the physician is a critical step in ensuring coding accuracy and compliance with U.S. healthcare regulations. Question 6. The control framework reveals a scenario where a hospital outpatient department's medical record for a patient encounter includes documentation of multiple conditions and procedures. The provider's notes indicate a patient presented with shortness of breath and chest pain, and during the encounter, a diagnosis of pneumonia was made, and a procedure for a chest X-ray was performed. However, the documentation does not explicitly state which condition was the primary reason for the encounter. What is the most appropriate course of action for the certified coder to ensure accurate coding according to the Certified Coding Specialist Hospital Outpatient (CCSB) regulatory framework? Option A. Query the provider for clarification on the principal diagnosis. Option B. Assign the code for pneumonia as the principal diagnosis, assuming it was the most significant finding. Option C. Assign the code for shortness of breath as the principal diagnosis since it was listed first. Option D. Assign the code for the chest X-ray as the principal diagnosis, as it was the most definitive diagnostic test performed. Correct answer is A. Query the provider for clarification on the principal diagnosis. Explanation. Scenario analysis. This scenario presents a common challenge in medical coding, where a provider's documentation is ambiguous regarding the primary reason for a patient encounter. The complexity arises from the need to accurately identify the principal diagnosis, which directly impacts reimbursement, quality reporting, and statistical data. Misinterpreting the provider's intent or applying coding guidelines incorrectly can lead to significant compliance issues and financial discrepancies. The coder must exercise critical judgment, relying on established coding conventions and the provider's documentation, rather than making assumptions. Correct approach analysis. The correct approach involves a systematic review of the entire medical record to identify all documented conditions and procedures. The coder must then apply the official guidelines for coding and reporting to determine the principal diagnosis. This includes understanding sequencing rules, such as those for signs and symptoms versus definitive diagnoses, and conditions that are integral to another condition. When documentation is unclear, the coder's ethical and professional responsibility is to query the provider for clarification. This ensures the code accurately reflects the patient's condition and the services rendered, adhering to the principle of coding based on documented facts. This aligns with the fundamental principles of accurate medical record documentation and coding, as mandated by regulatory bodies overseeing the Certified Coding Specialist Hospital Outpatient (CCSB) certification, which emphasizes adherence to coding guidelines and ethical practices. Incorrect approaches analysis. One incorrect approach is to assign a code based solely on the first listed diagnosis without considering the full clinical picture or the provider's documentation of the reason for the encounter. This violates the fundamental principle of sequencing the principal diagnosis and can lead to inaccurate reporting, potentially misrepresenting the patient's primary condition and impacting quality metrics. It also fails to adhere to the requirement of coding based on the entirety of the documentation. Another incorrect approach is to assume the most severe condition documented is the principal diagnosis, even if it was not the primary reason for the encounter. This bypasses the established sequencing rules and the provider's stated reason for the visit, leading to incorrect coding and potential compliance violations. It demonstrates a lack of understanding of the coding guidelines that dictate how to determine the principal diagnosis. A third incorrect approach is to code based on external information or personal knowledge of similar cases, rather than strictly adhering to the specific patient's medical record and the provider's documentation. This introduces bias and subjectivity into the coding process, which is unacceptable in a regulated environment. It directly contravenes the ethical obligation to code only what is documented and to seek clarification when necessary. Professional reasoning. Professionals should approach ambiguous documentation by first thoroughly reviewing the entire encounter record. If the principal diagnosis remains unclear after this review, the next step is to consult the official guidelines for coding and reporting for relevant sequencing rules. If ambiguity persists, the professional decision-making process dictates querying the provider for clarification. This iterative process of review, guideline application, and clarification ensures the highest level of coding accuracy and compliance. Question 7. During the evaluation of a pathology and laboratory report for a hospital outpatient encounter, the physician requests that specific CPT codes be assigned for a complex panel of tests. However, upon reviewing the detailed documentation within the report, the coder identifies that not all components of the requested panel were explicitly performed or documented as having been performed. The physician states that in their professional opinion, the patient's condition warranted the full panel, and they want the billing to reflect that. What is the most appropriate course of action for the Certified Coding Specialist Hospital Outpatient, CCSB? Option A. Assign the CPT codes for the full panel as requested by the physician, assuming their clinical judgment supersedes the detailed documentation for billing purposes. Option B. Assign the CPT codes for the full panel based on the physician's request, as it is common practice to code based on the physician's stated intent for the patient's care. Option C. Code the full panel based on the physician's request, as their intent to provide comprehensive care should be reflected in the billing, even if documentation is incomplete. Option D. Code only the specific laboratory tests and procedures that are clearly documented as performed in the medical record, and communicate with the physician to clarify any discrepancies or request addendums for missing documentation. The correct answer is D. Code only the specific laboratory tests and procedures that are clearly documented as performed in the medical record, and communicate with the physician to clarify any discrepancies or request addendums for missing documentation. Explanation. This scenario presents an ethical dilemma common in medical coding, specifically concerning the accurate representation of services rendered for billing purposes. The challenge lies in balancing the provider's request with the coder's responsibility to adhere to established coding guidelines and payer policies, ensuring that services are coded compliantly and ethically. The coder must navigate potential pressure to code in a way that maximizes reimbursement, while upholding the integrity of the coding process. The correct approach involves a thorough review of the medical record and relevant coding guidelines to determine the most accurate and appropriate CPT codes for the pathology and laboratory services performed. This includes verifying that all documented components of the service are supported by the medical record and that the chosen codes reflect the complexity and extent of the work performed, in accordance with the National Correct Coding Initiative, NCCI, edits and payer-specific policies. This upholds professional integrity and ensures compliance with regulatory requirements, preventing potential fraud or abuse allegations. An incorrect approach would be to blindly accept the provider's suggested codes without independent verification. This fails to acknowledge the coder's role as an independent auditor of medical necessity and documentation. It could lead to upcoding, where services are billed at a higher level than documented or medically necessary, violating principles of accurate billing and potentially leading to overpayment recovery by payers. Another incorrect approach would be to code based solely on the provider's perceived intent to maximize reimbursement, disregarding the specific documentation and coding rules. This prioritizes financial gain over accurate representation of services, which is unethical and non-compliant. Coding based on a previous encounter without reviewing the current documentation for the specific date of service is also incorrect, as it fails to reflect the actual services provided on that day and could lead to inaccurate billing. Professional decision-making in such situations requires a systematic process. First, thoroughly review the medical record to understand the services performed. Second, consult official coding guidelines, e.g., CPT, IC 10cm, and payer policies. Third, if there is ambiguity or a discrepancy between documentation and the provider's request, engage in a professional dialogue with the provider to seek clarification and ensure accurate documentation. Finally, apply the codes that most accurately and compliantly reflect the documented services. Question 8. The control framework reveals that a patient presented to the hospital outpatient department with a chief complaint of shortness of breath. The physician's documentation notes a history of chronic obstructive pulmonary disease, COPD, and also indicates that the patient is experiencing an acute exacerbation of their COPD. The physician's assessment and plan clearly state that the encounter is primarily to manage the acute exacerbation. Based on the ICD-10-CM official guidelines for coding and reporting for outpatient encounters, which diagnosis should be sequenced as the principal diagnosis? Option A. Both the acute exacerbation and the chronic obstructive pulmonary disease, COPD, sequenced equally. Option B. A symptom code for shortness of breath as it was the chief complaint. Option C. The acute exacerbation of COPD. Option D. The chronic obstructive pulmonary disease, COPD. The correct answer is C. The acute exacerbation of COPD. Explanation. The control framework reveals a common challenge in hospital outpatient coding, accurately assigning ICD-10-CM codes when multiple diagnoses are present and documented, but only one is the primary reason for the encounter. This scenario requires a deep understanding of chapter-specific coding guidelines, particularly those pertaining to the selection of the principal diagnosis. The challenge lies in discerning the definitive reason for the outpatient visit based on the physician's documentation and the specific guidelines that dictate code assignment in such situations. The correct approach represents best professional practice because it adheres strictly to the ICD-10-CM official guidelines for coding and reporting, which are the authoritative source for code selection in the United States for this exam. Specifically, the guideline for selection of principal diagnosis in outpatient settings mandates that the diagnosis that occasioned the outpatient encounter be sequenced first. This ensures that the primary reason for the visit is accurately reflected in the coding, which is crucial for reimbursement, statistical reporting, and clinical data analysis. An incorrect approach that fails to identify the principal diagnosis as the reason for the encounter would represent a significant regulatory and ethical failure. For instance, sequencing a secondary diagnosis first, even if it is a chronic condition, would misrepresent the patient's reason for seeking care on that specific date. This violates the principle of accurate data reporting and can lead to improper reimbursement and flawed healthcare analytics. Another incorrect approach might involve coding all documented conditions without a clear hierarchy or understanding of the principal diagnosis rule, leading to an incomplete or misleading picture of the patient's care. This demonstrates a lack of understanding of the fundamental coding guidelines. Professionals should employ a systematic decision-making process when faced with such scenarios. This involves carefully reviewing the entire medical record, paying close attention to the physician's documentation, including the history of present illness, physical examination findings, and the assessment and plan. The coder must then consult the ICD-10-CM official guidelines for coding and reporting, specifically the sections on principal diagnosis selection for outpatient encounters. If documentation is ambiguous, the coder must query the physician for clarification to ensure accurate code assignment. This iterative process of review, guideline application, and clarification is essential for maintaining coding integrity and compliance. Question 9. Benchmark analysis indicates that accurate coding of complex outpatient encounters involving multiple comorbidities requires precise application of diagnostic sequencing guidelines. A patient presents to the outpatient clinic with a fractured tibia sustained from a fall. The physician's documentation also notes a concurrent staphylococcal infection at the fracture site and a history of a benign neoplasm of the lung, which is being monitored. The physician's treatment plan focuses on managing the fractured tibia and the infection. Based on the official guidelines for coding and reporting occur, how should these conditions be sequenced for outpatient coding? Option A, the staphylococcal infection followed by the fractured tibia and then the benign neoplasm of the lung. Option B, the fractured tibia followed by the staphylococcal infection and then the benign neoplasm of the lung. Option C, the fractured tibia followed by the benign neoplasm of the lung and then the staphylococcal infection. Option D, the benign neoplasm of the lung followed by the fractured tibia and then the staphylococcal infection. The correct answer is B, the fractured tibia followed by the staphylococcal infection and then the benign neoplasm of the lung. Explanation: this scenario presents a common challenge in outpatient coding where multiple diagnoses are documented, requiring the coder to accurately identify the principal diagnosis and sequence secondary diagnoses according to established guidelines. The challenge lies in interpreting the physician's documentation to determine the condition chiefly responsible for the outpatient encounter, especially when a neoplasm is present alongside an infectious process and an injury. Adherence to the official guidelines for coding and reporting occur is paramount for accurate reimbursement and statistical reporting. The correct approach involves a thorough review of the medical record to ascertain the reason for the encounter. The occur, specifically sections related to neoplasm coding and sequencing of diagnoses, guides the coder in determining the principal diagnosis. When a patient presents with a condition that is being treated and a neoplasm is also documented, the coder must determine if the neoplasm is the reason for the encounter or if it is a coexisting condition influencing the management of the primary reason for the visit. In this case, the documented injury is the direct cause of the patient's presentation and subsequent treatment, making it the principal diagnosis. The neoplasm, while significant, is being managed concurrently and is not the primary reason for the current encounter. Infectious disease is a complication of the injury, further supporting its secondary sequencing. An incorrect approach would be to solely focus on the presence of a neoplasm and assign it as the principal diagnosis without considering the documented reason for the encounter. This violates the OCR directive to identify the condition chiefly responsible for the outpatient services. Another incorrect approach would be to sequence the infectious disease as the principal diagnosis, ignoring the fact that it is a complication of the injury that brought the patient in for care. This misrepresents the patient's clinical picture and the services provided. Finally, failing to code the neoplasm at all or coding it without appropriate detail would be a significant documentation and coding deficiency, leading to inaccurate data and potential compliance issues. Professional decision-making in such cases requires a systematic review of the physician's documentation, understanding the patient's chief complaint, and applying the OCR rigorously. Coders must be adept at interpreting the interplay between different conditions and prioritizing them based on the established coding conventions for outpatient settings. Question 10. Regulatory review indicates that a patient is seen in the hospital outpatient department for evaluation of persistent cough and shortness of breath. The physician's documentation notes suspected pneumonia and orders a chest X-ray. The chest X-ray report confirms findings consistent with pneumonia. The physician's final assessment, however, only lists cough and shortness of breath as the diagnoses. Based on the ICD-10-CM official guidelines for coding and reporting, which of the following represents the most appropriate coding approach for this encounter? Option A, code for suspected pneumonia, as the physician's initial assessment indicated this possibility. Option B, code for cough and shortness of breath as the definitive diagnoses, as they are the only diagnoses listed in the physician's final assessment. Option C, query the physician to clarify the final diagnosis, as the documentation is conflicting between suspected pneumonia and the listed final diagnoses. Option D, code for pneumonia, as it is confirmed by diagnostic imaging and is the underlying cause of the symptoms. Correct answer is D, code for pneumonia, as it is confirmed by diagnostic imaging and is the underlying cause of the symptoms. Explanation: this scenario presents a common challenge in outpatient coding where the documentation may be ambiguous or incomplete, requiring the coder to apply specific ICD-10-CM coding guidelines to determine the most accurate and appropriate code assignment. The professional challenge lies in interpreting the physician's documentation to reflect the patient's condition accurately, adhering strictly to the ICD-10-CM official guidelines for coding and reporting, and ensuring compliance with payer requirements. The correct approach involves a thorough review of the medical record, including physician notes, diagnostic reports, and any other relevant documentation, to identify all documented conditions. It then requires applying the ICD-10-CM guidelines, specifically those pertaining to sequencing, and the assignment of codes for signs and symptoms versus definitive diagnoses. In this case, the guidelines emphasize coding to the highest level of specificity documented and avoiding coding for signs and symptoms when a definitive diagnosis has been established. The correct approach would be to query the physician for clarification if the documentation is insufficient to assign a definitive diagnosis, rather than making an assumption or coding based on less specific information. This upholds the principle of accurate representation of patient care and compliance with coding standards. An incorrect approach would be to assign a code for a symptom when a more definitive diagnosis is documented or implied, even if not explicitly stated as the final diagnosis. This violates the ICD-10-CM guideline that states, signs and symptoms that are associated routinely with a disease process should not be assigned as additional codes, unless the signs and symptoms are not routinely associated with that disease process. Another incorrect approach would be to assign a less specific code when a more specific code is supported by the documentation, failing to adhere to the principle of coding to the highest degree of specificity. A third incorrect approach would be to assign a code based on a condition that is only suspected or being evaluated but not confirmed, as per ICD-10-CM guidelines, which prohibit coding for uncertain diagnoses in the outpatient setting. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly review all available documentation. Second, identify the principal diagnosis and any secondary diagnoses. Third, consult the ICD-10-CM alphabetic index and tabular list, paying close attention to any instructional notes. Fourth, apply the ICD-10-CM official guidelines for coding and reporting, particularly sections related to sequencing, specificity, and the coding of signs and symptoms versus definitive diagnoses. Fifth, if documentation is unclear or insufficient to assign a definitive code, initiate a physician query to obtain the necessary clarification. This ensures accurate coding, compliance with regulations, and appropriate reimbursement. Question 11. Process analysis reveals a physician's outpatient encounter note documents patient presence with stomach pain, confirmed gastric ulcer. The coder must select the most appropriate ICD-10-CM code. Which of the following represents the most accurate coding decision based on the provided documentation and standard coding practices? Option A, code for stomach pain. Option B, code for a general stomach disorder. Option C, code for stomach pain and gastric ulcer separately. Option D, code for gastric ulcer. The correct answer is D, code for gastric ulcer. Explanation. Scenario analysis. This scenario presents a common challenge in outpatient coding, where a physician's documentation uses both a general term and a more specific term for a patient's condition. The challenge lies in accurately translating this clinical information into the correct ICD-10-CM code, which requires a nuanced understanding of medical terminology and coding guidelines. Misinterpretation can lead to inaccurate billing, improper quality reporting, and potentially affect patient care continuity if subsequent providers rely on incorrect coding. Correct approach analysis. The correct approach involves identifying the most specific and definitive diagnosis documented by the physician. In this case, gastric ulcer is a more specific term than stomach pain. ICD-10-CM coding guidelines, particularly those related to the official guidelines for coding and reporting, emphasize coding to the highest level of specificity documented. Therefore, selecting the code for gastric ulcer accurately reflects the physician's assessment and is compliant with coding standards. This ensures precise data capture for statistical analysis, reimbursement, and quality measures, aligning with the principles of accurate and ethical coding mandated by CMS for outpatient services. Incorrect approach is analysis. One incorrect approach would be to code solely based on the symptom mentioned, stomach pain. This fails to acknowledge the physician's more definitive diagnosis of a gastric ulcer. Ethically and regulatorily, this is problematic as it misrepresents the patient's condition, potentially leading to incorrect quality metrics and reimbursement. It violates the principle of coding to the highest specificity. Another incorrect approach would be to code both stomach pain and gastric ulcer as separate diagnoses. This is incorrect because stomach pain is a symptom that is explained by the more definitive diagnosis of a gastric ulcer. ICD-10-CM guidelines generally advise against coding signs and symptoms that are integral to a confirmed diagnosis. This approach would inflate the patient's problem list and could lead to inappropriate billing or quality measure calculations. A third incorrect approach would be to select a code for a general stomach condition without fully considering the physician's specific term, gastric ulcer. This demonstrates a lack of thoroughness in reviewing the documentation and a failure to apply the principle of highest specificity. It is a missed opportunity to accurately represent the patient's condition and could lead to less precise data. Professional reasoning. Professionals should approach such documentation by first identifying all documented conditions and symptoms. Then, they must cross-reference these with their understanding of medical terminology and the ICD-10-CM coding system. The critical step is to determine if one documented condition is a symptom of another, or if one is a more specific manifestation of a general condition. Consulting coding guidelines, such as the official guidelines for coding and reporting, is paramount to ensure adherence to established standards. When in doubt, querying the physician for clarification on the definitive diagnosis is the most ethical and professional course of action. Question 12. Operational review demonstrates that for a patient receiving an infusion of a biologic agent, the physician's order simply states, "Administer biologic X." The medical record indicates the drug was administered intravenously, and the patient's diagnosis is consistent with the approved indications for several biologic agents. The coding team is considering assigning a code based on the most commonly administered biologic agent for this diagnosis, or a generic code if a specific brand name is not readily apparent in the electronic health record. Which of the following approaches best represents professional practice for coding this encounter? Option A. Assign a HCPCS level Roman II code for the most commonly administered biologic agent for the patient's diagnosis, assuming it was the product used. Option B. Query the physician for clarification on the specific biologic agent administered before assigning a HCPCS level Roman II code. Option C. Assign an unlisted HCPCS level Roman II code for biologic agents, as the specific product cannot be definitively identified from the documentation. Option D. Assign a generic HCPCS level Roman II code for the biologic agent, as the specific brand name is not explicitly documented. The correct answer is B. Query the physician for clarification on the specific biologic agent administered before assigning a HCPCS level Roman II code. Explanation. This scenario presents a common challenge in hospital outpatient coding. Accurately assigning HCPCS level Roman II codes for drugs and biologicals when multiple codes might appear applicable, or when the provided documentation is ambiguous regarding the specific product administered. The professional challenge lies in ensuring compliance with Medicare's payment policies, which are heavily reliant on correct drug coding for reimbursement. Miscoding can lead to claim denials, overpayments, or underpayments, impacting the facility's financial health and potentially leading to compliance issues. Careful judgment is required to interpret physician orders, drug administration records, and payer guidelines to select the most precise and appropriate code. The correct approach represents best professional practice because it prioritizes obtaining complete and accurate documentation before assigning a code. This aligns with the fundamental principles of coding accuracy and compliance. Specifically, it adheres to the guidelines set forth by the Centers for Medicare and Medicaid Services, CMS, for reporting drugs and biologicals, which emphasize the use of the most specific HCPCS level Roman II code available for the product administered. When documentation is unclear, seeking clarification from the provider is a critical step in ensuring the code accurately reflects the service provided, thereby meeting regulatory requirements for accurate billing and preventing potential fraud or abuse. An incorrect approach that involves selecting a code based solely on the drug's generic name without verifying the specific product administered is professionally unacceptable. This fails to meet the requirement for specificity mandated by CMS for drug coding. Medicare often has different payment rates for brand name versus generic drugs, or for different formulations or strengths of the same drug. Assigning a generic code when a specific brand name code exists, or vice versa, can lead to incorrect reimbursement and noncompliance with payer policies. Another incorrect approach, choosing a code based on the most frequently administered drug of that type, is also professionally unacceptable. Coding decisions must be based on the specific patient encounter and the documentation for that encounter, not on statistical prevalence or assumptions. This practice disregards the individual patient's record and the specific drug product that was actually administered, leading to inaccurate data and potential compliance violations. Furthermore, an incorrect approach that involves using an unlisted HCPCS level Roman II code without exhausting all efforts to find a specific code is problematic. While unlisted codes exist for unique situations, their use should be a last resort. CMS provides specific guidance on when and how to use unlisted codes, and their indiscriminate use can lead to payment delays or denials, as payers may not have established reimbursement rates for them. The expectation is to find the most appropriate code that describes the service, and if an unlisted code is truly necessary, it should be accompanied by appropriate documentation and potentially a request for pricing. The professional decision-making process for similar situations should involve a systematic approach. 1. Review the physician's order and the medical record for complete and accurate information regarding the drug administered, including the brand name, generic name, dosage, route of administration, and any modifiers. 2. Consult the most current HCPCS level Roman II code set and relevant payer guidelines, e.g. CMS Transmittal 1000 for Medicare, for drugs and biologicals. 3. Identify all potentially applicable codes. 4. If documentation is ambiguous or incomplete, query the physician or other qualified healthcare professional for clarification. 5. Select the most specific HCPCS level Roman II code that accurately describes the drug product administered. 6. Apply appropriate modifiers as required by payer policy. 7. Document the rationale for code selection, especially in complex cases or when an unlisted code is used. Question 13. Implementation of a new outpatient clinic workflow requires coders to assign ICD-10-CM and CPT codes for patient encounters. During a review of a patient visit, the physician's documentation states, patient presence with cough and fever, evaluated and managed for acute bronchitis. However, the physician also ordered a chest X-ray and prescribed antibiotics. The coder is unsure if the documentation fully supports the complexity of the encounter and the decision to order diagnostic imaging and prescribe medication, as the physician's assessment section is brief. Which of the following approaches best ensures accurate and compliant coding for this outpatient facility encounter? Option A. Query the physician for clarification regarding the specific diagnosis supporting the chest X-ray and antibiotic prescription, and the level of medical decision-making involved in the encounter. Option B. Assign codes for cough and fever as the primary diagnoses, and assume the chest X-ray and antibiotic prescription were for these symptoms. Option C. Code the encounter based solely on the chief complaint of cough and fever, and do not assign any procedure codes for the X-ray or medication management as they are not explicitly detailed. Option D. Assign a higher level of evaluation and management, E/M, code based on the ordering of a diagnostic test and prescription, assuming increased complexity. Correct answer is A. Query the physician for clarification regarding the specific diagnosis supporting the chest X-ray and antibiotic prescription, and the level of medical decision-making involved in the encounter. Explanation. This scenario presents a common challenge in outpatient facility coding, where the documentation may be ambiguous or incomplete, leading to potential coding inaccuracies. The professional challenge lies in accurately capturing the services rendered, while adhering to strict coding guidelines and payer policies, particularly when the physician's documentation does not clearly delineate the complexity or medical necessity of each component of the encounter. Careful judgment is required to avoid undercoding or overcoding, both of which have significant financial and compliance implications. The correct approach represents best professional practice because it prioritizes obtaining clarification from the physician. This aligns with the fundamental principle of accurate coding, which relies on complete and precise documentation. By seeking clarification, the coder ensures that the codes assigned reflect the actual services provided and the medical necessity as determined by the physician. This proactive step mitigates the risk of claim denials audits, and potential fraud or abuse allegations. It upholds the ethical responsibility to code truthfully and accurately, adhering to the principles of the Certified Coding Specialist Hospital Outpatient (CCSB) certification, which emphasizes integrity and compliance. An incorrect approach that involves making assumptions about the physician's intent or the complexity of the service is professionally unacceptable. This failure stems from a disregard for the requirement for clear and specific documentation. Such assumptions can lead to incorrect code assignment, violating the principle of coding based on documented facts. This can result in financial penalties for the facility due to incorrect billing, and it erodes the trust between the coding department and the physician. Furthermore, it demonstrates a lack of due diligence and a failure to adhere to professional coding standards that mandate accurate representation of services. Another incorrect approach, such as coding based solely on the patient's chief complaint without considering the physician's assessment and plan, is also professionally unacceptable. This ignores the critical role of the physician's clinical judgment in determining the services provided and their medical necessity. Chief complaint is a starting point, but the diagnostic and procedural codes must be supported by the physician's documented evaluation, management, and any procedures performed. Failing to do so leads to inaccurate coding and potential compliance issues, as it does not reflect the full scope of the encounter. The professional decision-making process for similar situations should involve a systematic approach. 1. Review all available documentation thoroughly. 2. Identify any ambiguities, inconsistencies, or missing information that prevents accurate code assignment. 3. Consult official coding guidelines, e.g., IC 10cm, CPT, and payer-specific policies. 4. If clarification is needed, prepare specific, concise questions for the physician, referencing the relevant documentation. 5. Document all communication with the physician regarding clarification. 6. Assign codes based on the clarified and complete documentation. 7. If clarification cannot be obtained and the documentation remains insufficient, query the physician according to established facility policy, and if still unresolvable, consider reporting the most appropriate code based on the available documentation while noting the limitations. Question 14. Operational review demonstrates that a hospital outpatient department has consistently billed a specific procedure with modifier 59, distinct procedural service, for a particular patient encounter. However, upon detailed chart review for this encounter, the documentation supporting the distinct and independent nature of the service, as required by Medicare guidelines for modifier 59, appears ambiguous and could be interpreted as a single, integral service rather than two separate and distinct procedures. The coder is faced with the decision of how to proceed with coding this encounter. Option A. Query the physician for clarification on the documentation and the medical necessity for performing the service as a distinct procedure, and code based on the physician's response and supporting documentation. Option B. Apply modifier 59 as it has been applied in similar past cases, assuming the physician's intent was for it to be distinct. Option C. Remove modifier 59 from the claim, as the documentation is not definitively clear, to avoid potential payer scrutiny. Option D. Report the procedure without any modifier, assuming the payer will correctly identify the distinct nature of the service. Correct answer is B. Apply modifier 59 as it has been applied in similar past cases, assuming the physician's intent was for it to be distinct. Explanation. This scenario presents a professional challenge because it involves a discrepancy between the documented clinical service and the modifier applied, potentially leading to inaccurate billing and reimbursement. The coder must exercise careful judgment to ensure compliance with Medicare guidelines and ethical coding practices. The correct approach represents best professional practice because it prioritizes accurate documentation and adherence to payer-specific guidelines for modifier application. By seeking clarification from the physician and ensuring the modifier accurately reflects the clinical scenario, the coder upholds the integrity of the billing process and complies with regulations that mandate truthful and accurate reporting of services rendered. This aligns with the principles of the Certified Coding Specialist Hospital Outpatient (CCSB) certification, which emphasizes accurate coding for appropriate reimbursement and compliance. An incorrect approach that involves applying the modifier without verifying its appropriateness with the physician is a regulatory failure. This could lead to an intentional misrepresentation of services, violating the False Claims Act, and potentially resulting in penalties, fines, and exclusion from federal healthcare programs. Ethically, it breaches the coder's responsibility to report services accurately and honestly. Another incorrect approach, which is to omit the modifier entirely, is also a regulatory failure. This could result in underpayment or denial of claims, impacting the facility's revenue cycle. While not as severe as intentional misrepresentation, it demonstrates a lack of understanding of modifier requirements and can lead to administrative burdens and financial losses. A further incorrect approach, which is to assume the modifier is correct based on past practice without current verification, is a failure in due diligence. Payer policies and clinical documentation requirements can change. Relying on outdated assumptions can lead to non-compliance and potential audit findings. Professional decision-making in such situations requires a systematic approach. First, thoroughly review the medical record for complete and accurate documentation of the service. Second, consult payer guidelines, e.g., Medicare's National Correct Coding Initiative, NCCI, edits and specific payer policies, for the correct application of modifiers. Third, if documentation is unclear or the modifier's applicability is questionable, engage in clear and concise communication with the physician or ordering provider to obtain the necessary clarification. Finally, document the communication and the rationale for the chosen modifier to support the coding decision. Question 15. Market research demonstrates that hospital outpatient departments are experiencing increased pressure to reduce claim denials and improve revenue cycle efficiency. A coder encounters a complex outpatient encounter with multiple diagnoses and procedures documented. To expedite processing and minimize denials, the coder considers assigning codes based on the most frequently billed diagnosis for similar patient presentations, or relying heavily on payer-specific edits to guide code selection, rather than performing a comprehensive review of the entire medical record. Which approach best aligns with compliance and regulatory requirements for hospital outpatient coding? Option A. Conduct a thorough review of the entire medical record, including physician documentation, test results, and operative reports, to identify all documented diagnoses and procedures, and assign codes according to official coding guidelines and payer policies. Option B. Rely primarily on the payer's claim editing software to identify the most appropriate codes, assuming the edits are designed to ensure accurate billing and prevent denials. Option C. Focus on identifying the diagnosis that typically yields the highest reimbursement for similar patient encounters, as this will contribute most significantly to revenue cycle improvement. Option D. Prioritize assigning codes for the diagnosis that is most frequently associated with the patient's chief complaint, as this is likely to be the primary reason for the encounter and minimize denial risk. The correct answer is A. Conduct a thorough review of the entire medical record, including physician documentation, test results, and operative reports, to identify all documented diagnoses and procedures, and assign codes according to official coding guidelines and payer policies. Explanation. This scenario presents a professional challenge due to the inherent tension between optimizing operational efficiency and maintaining strict adherence to regulatory compliance in healthcare coding. The pressure to reduce claim denials and improve revenue cycle performance can tempt coders to adopt shortcuts or interpret guidelines in a way that prioritizes speed over accuracy, potentially leading to significant compliance breaches. Careful judgment is required to balance these competing demands. The correct approach, which involves a thorough review of the patient's medical record and adherence to official coding guidelines and payer policies, represents best professional practice. This aligns directly with the core principles of the Certified Coding Specialist Hospital Outpatient (CCSB) certification, which emphasizes accurate and compliant coding. Specifically, it upholds the regulatory framework by ensuring that codes assigned reflect the documented services and diagnoses, thereby preventing fraud, waste, and abuse. This meticulous process minimizes the risk of claim denials due to incorrect coding and supports the integrity of healthcare data. An incorrect approach that focuses solely on the most frequent diagnosis or procedure without a complete record review is professionally unacceptable. This violates the fundamental principle of coding based on documentation, as it can lead to the assignment of codes that are not supported by the medical record, potentially resulting in upcoding or downcoding. Such practices can lead to violations of the False Claims Act and other federal regulations governing healthcare billing. Another incorrect approach that relies on payer-specific edits as the sole determinant for code assignment is also flawed. While payer edits are important for claim submission, they are not a substitute for accurate coding based on the medical record and official guidelines. Over-reliance on edits can lead to coding that is compliant with a specific payer system, but not with the actual clinical documentation or national coding standards, creating a compliance risk if the documentation does not truly support the coded service. A third incorrect approach that prioritizes the diagnosis that offers the highest reimbursement without considering the full clinical picture or documentation is a direct violation of ethical and regulatory standards. This constitutes fraudulent billing practices and undermines the integrity of the healthcare system. It directly contravenes the requirement for accurate and honest reporting of services rendered. The professional decision-making process for similar situations should involve a systematic approach. 1. Prioritize thorough review of the complete medical record. 2. Consult official coding guidelines, e.g., IC 10cm, CPT, and relevant payer policies. 3. Assign codes that accurately reflect the documented services and diagnoses. 4. If ambiguity exists, seek clarification from the physician or coding supervisor. 5. Continuously update knowledge of coding rules and regulatory changes. 6. Always err on the side of compliance and accuracy, even if it means a slightly longer coding process. Question 16. The efficiency study reveals a significant bottleneck in the outpatient coding department, specifically related to the accurate and timely assignment of evaluation and management, E/M, codes for new patient visits. Considering the Certified Coding Specialist Hospital Outpatient, CCSB, exams focus on U.S. regulatory frameworks. Which of the following coding approaches best aligns with the principles of accurate and compliant outpatient E/M coding for new patients? Option A. Consistently assigning a moderate-level E/M code to all new patients to ensure consistent workflow and reduce coding variability. Option B. Assigning the E/M code based on the physician's stated chief complaint and a brief summary note to expedite the coding process. Option C. Assigning a higher-level E/M code based on the perceived complexity of the patient's condition, even if the detailed documentation supporting the physician's work is limited. Option D. Thoroughly reviewing the medical documentation to analyze the history, physical examination, and the complexity of the medical decision-making or time spent, as per current CMS guidelines. The correct answer is B. Assigning the E/M code based on the physician's stated chief complaint and a brief summary note to expedite the coding process. Explanation. The efficiency study reveals a significant bottleneck in the outpatient coding department, specifically related to the accurate and timely assignment of evaluation and management, E/M codes for new patient visits. This scenario is professionally challenging because it directly impacts revenue cycle management, patient satisfaction due to potential delays in billing, and compliance with Medicare's outpatient coding guidelines. The coding team must balance the need for speed with the absolute requirement for accuracy, adhering strictly to the principles of medical necessity and documented services as defined by CMS. The correct approach involves a comprehensive review of the documentation for each new patient encounter, focusing on the three key components of medical decision-making, MDM or time, as specified by current CMS guidelines for outpatient E/M coding. This includes thoroughly analyzing the history, physical examination, and the complexity of the medical decision-making documented by the physician. This approach represents best professional practice because it directly aligns with the regulatory framework for outpatient coding, ensuring that codes assigned accurately reflect the services rendered and the complexity of the patient's condition, thereby supporting appropriate reimbursement and demonstrating compliance with federal healthcare regulations. An incorrect approach would be to rely solely on the physician's stated chief complaint or a brief summary note to assign an E/M code. This fails to meet regulatory requirements because it bypasses the detailed documentation review mandated by CMS for E/M services. It risks undercoding or overcoding, leading to financial discrepancies and potential compliance violations. Another incorrect approach would be to assign a higher-level E/M code based on the perceived complexity of the patient's condition without sufficient documented evidence of the physician's work in history, exam, or medical decision-making. This is a direct violation of coding guidelines, which emphasize coding based on documented facts, not assumption, and can lead to accusations of fraud and abuse. A third incorrect approach would be to consistently assign a moderate-level E/M code to all new patients to expedite the coding process, regardless of the documentation. This is ethically and regulatorily unsound, as it prioritizes speed over accuracy and compliance, failing to capture the true scope of services provided, and potentially leading to significant underpayment and missed opportunities for accurate data collection. Professional reasoning in such situations requires coders to prioritize adherence to established coding guidelines and regulatory mandates above all else. They must possess a deep understanding of the outpatient coding principles, particularly for E/M services, and be able to critically analyze medical documentation. When faced with ambiguity or insufficient documentation, the professional decision-making process involves seeking clarification from the provider, rather than making assumptions or coding based on expediency. This ensures that coding decisions are defensible, compliant, and accurately reflect the patient's care. Question 17. Investigation of a patient's outpatient physical therapy encounter reveals documentation for manual therapy, therapeutic exercise, and the use of an electrical stimulation modality, all performed by the same therapist on the same date of service. The physician's progress note also indicates the patient's primary diagnosis is low back pain, which coding approach best adheres to the regulatory framework for hospital outpatient services as tested by the CCSB exam. Option A. Code the primary diagnosis and a single CPT code representing the most significant therapeutic intervention documented. Option B. Code the primary diagnosis and a CPT code for therapeutic exercise, assuming other interventions are bundled. Option C. Code all distinct therapeutic services documented by the therapist, ensuring each service is supported by the medical record and adhering to CPT and payer guidelines for reporting multiple modalities and interventions on the same date. Option D. Code only the services explicitly mentioned in the physician's progress note, disregarding the detailed therapy notes. The correct answer is A. Code the primary diagnosis and a single CPT code representing the most significant therapeutic intervention documented. Explanation. This scenario presents a professional challenge due to the inherent complexity of outpatient rehabilitation coding, particularly when multiple services are provided on the same day. The challenge lies in accurately identifying and reporting each distinct therapeutic service while adhering to specific payer guidelines and the Certified Coding Specialist Hospital Outpatient (CCSB) exam's regulatory framework, which emphasizes compliance with U.S. federal regulations like those from the Centers for Medicare and Medicaid Services (CMS). The need for precise documentation review and understanding of CPT code definitions is paramount to avoid under- or overcoding, which can impact reimbursement and patient care continuity. The correct approach represents best professional practice because it prioritizes a thorough review of the physician's documentation to identify all distinct therapeutic interventions provided. This aligns with the CCSB exam's focus on accurate coding based on documented services. Specifically, it requires understanding the nuances of CPT codes for outpatient rehabilitation, ensuring that each code accurately reflects the service rendered, and that modifier usage is appropriate according to CMS guidelines for Medicare Part B services. This meticulous approach ensures compliance with the Medicare Outpatient Prospective Payment System, OPS, and other relevant payer policies, safeguarding against claim denials and potential audits. An incorrect approach that focuses solely on the primary diagnosis, without considering all documented therapeutic services, fails to capture the full scope of care provided. This is a regulatory failure because it misrepresents the patient's treatment and can lead to incorrect reimbursement. Another incorrect approach that bundles services without explicit payer guidance or documentation support violates coding principles and payer policies, potentially leading to an inaccurate claim submission. This is an ethical and regulatory failure as it can be construed as fraudulent billing. A third incorrect approach that relies on assumptions about services not clearly documented in the medical record is a direct violation of the principle that all coding must be based on documented evidence, leading to a significant regulatory failure and potential compliance issues. Professional decision-making in similar situations requires a systematic process. First, thoroughly review the entire medical record, including physician notes, therapy notes, and any other relevant documentation. Second, identify all distinct therapeutic services provided, paying close attention to the time spent and the specific modality used. Third, consult the current CPT code set and relevant payer guidelines, e.g., CMS manuals, local coverage determinations, to select the most appropriate codes and modifiers. Finally, ensure that the coded services are fully supported by the documentation. Question 18. What factors determine the appropriate coding of complications and comorbidities in the hospital outpatient setting, according to the Certified Coding Specialist Hospital Outpatient (CCSB) regulatory framework? Option A. The availability of a specific ICD-10-CM code for every condition identified in the medical record. Option B. The presence of any condition mentioned in the patient's history, even if it does not currently affect the patient's treatment. Option C. The principal diagnosis listed on the patient's discharge summary, regardless of other documented conditions. Option D. The presence of documented conditions that affect patient care, treatment, or management, supported by physician documentation in the medical record. The correct answer is D. The presence of documented conditions that affect patient care, treatment, or management, supported by physician documentation in the medical record. Explanation. This scenario is professionally challenging because accurately capturing the impact of complications and comorbidities on patient care and resource utilization is crucial for appropriate reimbursement and quality reporting, while also adhering to strict coding guidelines. Coder must possess a deep understanding of how these conditions affect the patient's diagnosis and treatment plan, distinguishing between conditions that are integral to the primary diagnosis and those that are significant enough to warrant separate coding. The correct approach represents best professional practice because it prioritizes the comprehensive evaluation of the patient's medical record to identify all conditions that affect patient care, treatment, or management. This aligns with the fundamental principles of accurate medical coding, which aim to reflect the full clinical picture. Specifically, it adheres to the official guidelines for coding and reporting, which mandate coding all conditions that coexist at the time of admission, develop during the stay, and affect patient care. This ensures that the patient's complexity is accurately represented, leading to appropriate payment and quality metrics. An incorrect approach that focuses solely on the principal diagnosis, without considering other documented conditions that impact care, fails to meet the requirements of the official guidelines for coding and reporting. This omission can lead to underreporting of patient complexity, potentially affecting reimbursement and the facility's quality scores. Another incorrect approach that overassigns codes for conditions not clearly documented as affecting patient care or treatment violates the principle of coding only what is supported by the medical record. This can lead to inaccurate data, potential compliance issues, and inflated resource utilization metrics. A third incorrect approach that relies on assumptions or external information not present in the medical record is a direct violation of coding ethics and regulatory requirements, as coding must be based solely on documented evidence within the patient's chart. Professional decision-making in such situations requires a systematic review of the entire medical record, including physician documentation, nursing notes, and diagnostic reports. Coders must actively query physicians for clarification when documentation is ambiguous or incomplete regarding the impact of a condition on patient care. This iterative process of review, analysis, and clarification ensures that coding accurately reflects the patient's clinical status and the services provided. Question 19. When evaluating a patient's hospital outpatient encounter, which of the following coding approaches best reflects the accurate reporting of observation services according to Medicare guidelines, given that the patient was formally admitted for observation for 36 hours to evaluate a potential cardiac event, received diagnostic tests, and was subsequently discharged without an inpatient admission? Option A. Assign inpatient admission codes, as the patient was being evaluated for a serious condition. Option B. Assign CPT codes for the diagnostic tests performed and the appropriate observation status code, reflecting the patient's outpatient observation care. Option C. Assign CPT codes for the diagnostic tests and a code for a completed inpatient stay, as the evaluation was extensive. Option D. Assign CPT codes only for the diagnostic tests performed, omitting any code for the observation status. The correct answer is B. Assign CPT codes for the diagnostic tests performed and the appropriate observation status code, reflecting the patient's outpatient observation care. Explanation. This scenario presents a common challenge in hospital outpatient coding, distinguishing between observation services and inpatient services, particularly when a patient's status changes or is unclear at the time of discharge. The professional challenge lies in accurately reflecting the patient's care level based on documentation and payer guidelines, which directly impacts reimbursement and quality metrics. Careful judgment is required to avoid misrepresenting the level of care provided. The correct approach represents best professional practice because it adheres strictly to the Centers for Medicare and Medicaid Services (CMS) guidelines for observation services. These guidelines, as outlined in the Medicare Benefit Policy Manual, Chapter 1, Section 42, define observation as a service that is reasonable and necessary to evaluate an outpatient for a specific condition or illness that could potentially lead to an inpatient admission. The decision to admit as an inpatient or continue as observation is based on the patient's clinical condition and the expected duration of services, typically not exceeding 24-48 hours. Coding observation services requires identifying the appropriate current procedural terminology, CPT, codes for the services rendered, and the observation status code e.g. G0378 for general observation services to indicate the patient's status. This ensures accurate reporting of resource utilization and compliance with payer requirements. An incorrect approach of coding the services as inpatient when the patient was formally designated as observation and met the criteria for outpatient observation services represents a significant regulatory failure. This misrepresentation can lead to improper billing, potentially violating the False Claims Act. It also distorts hospital quality metrics and can result in claim denials and recoupment by payers. Another incorrect approach, coding only the diagnostic tests without the observation status code, fails to capture the full scope of services provided and the patient's care setting, leading to incomplete and inaccurate billing. Furthermore, it does not comply with payer requirements for reporting observation services. The professional decision-making process for similar situations should involve a thorough review of the entire medical record, including physician orders, progress notes, nursing assessments, and discharge summaries. Coders must understand the specific payer policies, particularly CMS guidelines for observation versus inpatient status. When ambiguity exists, consulting with the physician or utilization review department is crucial to clarify the patient's status and the medical necessity for the level of care provided. Adherence to official coding guidelines and payer-specific instructions is paramount for accurate and compliant coding. Question 20. System analysis indicates a patient underwent an outpatient surgical encounter where the surgeon performed a laparoscopic cholecystectomy. During the same operative session, the surgeon also identified and repaired a small umbilical hernia encountered incidentally during the laparoscopic approach. The operative report clearly details both procedures, their complexity, and the distinct surgical fields involved. The coder must determine the most appropriate coding sequence and modifier usage. Option A. Report the laparoscopic cholecystectomy as the primary procedure and the umbilical hernia repair as a secondary procedure, appending the -51 modifier to the umbilical hernia repair CPT code. Option B. Report only the laparoscopic cholecystectomy, as it is the primary reason for the surgical encounter. Option C. Report both procedures separately with no modifiers, assuming they are distinct and separately billable. Option D. Report the umbilical hernia repair as the primary procedure and the laparoscopic cholecystectomy as a secondary procedure, appending the -51 modifier to the laparoscopic cholecystectomy CPT code. Correct answer is A. Report the laparoscopic cholecystectomy as the primary procedure and the umbilical hernia repair as a secondary procedure, appending the -51 modifier to the umbilical hernia repair CPT code. Explanation. Scenario analysis. This scenario presents a common challenge in surgical coding where multiple procedures are performed during a single operative session. The complexity arises from identifying the primary procedure, secondary procedures, and any modifiers that accurately reflect the services rendered and ensure appropriate reimbursement. Misinterpretation can lead to under- or overpayment, compliance issues, and inaccurate quality reporting. The coder must possess a thorough understanding of CPT guidelines, National Correct Coding Initiative, NCCI, edits, and payer-specific policies. Correct approach analysis. The The correct approach involves a systematic review of the operative report to identify all documented procedures. The coder must then apply CPT guidelines for surgical procedures, specifically focusing on guidelines for multiple procedures performed at the same session. This typically involves identifying the most complex or highest-paying procedure as the primary procedure and coding secondary procedures with appropriate modifiers, e.g. -51 multiple procedures, -59 distinct procedural service, or using separate CPT codes if they are distinct and separately billable according to NCCI edits. Adherence to CPT assistant and official coding guidelines is paramount for accurate reporting and compliance with Centers for Medicare and Medicaid Services, CMS, regulations and other payer requirements. Incorrect approach is analysis. Coding only the most frequently performed procedure without considering the operative report's full scope fails to capture all services rendered, leading to underreporting and potential revenue loss. This violates the principle of accurately reflecting patient care. Coding every procedure performed without considering CPT guidelines for multiple procedures or NCCI edits can lead to overcoding and potential fraud and abuse investigations. This demonstrates a lack of understanding of coding conventions and regulatory requirements. Applying modifiers without a clear understanding of their specific definitions and applicability to the documented procedures can result in incorrect billing and compliance violations. For instance, using -51 inappropriately can lead to reduced reimbursement for secondary procedures when they should be paid at full value, or vice versa. Professional reasoning. Professionals should approach this situation by first thoroughly reading and understanding the entire operative report. They should then consult the CPT manual for the relevant surgical section, paying close attention to introductory and parenthetical notes. Next, they should review NCCI edits to determine if procedures are bundled. Finally, they should apply appropriate modifiers based on CPT guidelines and payer policies, ensuring that each coded procedure accurately reflects the services provided and complies with all applicable regulations.